So I will be discussing risk stratification of patients with cirrhosis who are undergoing surgery. I have no financial disclosures. I will be touching briefly on the epidemiology of cirrhosis and how there is a changing demographic in cases that we are seeing. I will be discussing sort of the theoretical and pathophysiologic risk in patients with cirrhosis who are undergoing surgery and why this population is of particular interest and requires special attention and care. I will also be discussing some predictive models that are out there to assess surgical risk. So I will touch briefly on the Child-Turco-Pugh classification, the MELD score, and then two novel risk calculators that can be utilized and have been validated as measures of risk stratification in patients with cirrhosis who are undergoing surgery. I will also be discussing particular surgical risks to consider by surgery type. And then lastly, just to touch base on patients in the post-operative period, what types of considerations and management they may require. So in terms of epidemiology of cirrhosis, so worldwide, the incidence of cirrhosis is increasing. So in 2009, there were 1.8 million incident cases of cirrhosis worldwide, which increased to 2.1 million globally in 2019. The other thing that we're seeing is a change in demographic. So with awareness of viral hepatitis worldwide, as well as increased vaccine uptake of hepatitis B, there's actually reduced incidence of viral hepatitis-related cirrhosis. And with that change, there's actually a rise in alcohol-related liver disease, as well as in MASLD or metabolic dysfunction-associated steatotic liver disease, it's a mouthful, related cirrhosis. And with patients that have MASLD or MASH-related cirrhosis, given that that population often has comorbidities, it's an older population, those patients in particular may be undergoing surgeries that we now need to consider more so than before. Additionally, our management of patients with cirrhosis has really advanced in recent years, and with that, patients are living longer and again may need to undergo surgery for that reason. So in terms of the pathophysiology of cirrhosis that can lead to this unfavorable risk profile, factors such as sarcopenia, malnutrition, and frailty, which is something that we particularly see in our patients with decompensated cirrhosis, can lead to poor postoperative outcomes, and in particular, may prohibit things such as wound healing. Also, the presence of portal hypertension with portosystemic collaterals, especially in the abdomen and in the thoracic cavity, may lead to excess or an unfavorable amount of bleeding. And then lastly, with cirrhosis, we do know that there's an imbalance of anticoagulant and procoagulant factors that may portend either excess bleeding or excess clotting. And lastly, there really are a lack of robust data to drive the surgical risk stratification. So many of the studies that are out there are retrospective. As you can imagine, it's difficult when patients with cirrhosis are undergoing urgent or emergent surgery. It would be very hard to do more prospective or randomized control trials in this patient population. And so there have been multiple models that have been proposed to assess surgical risk, and sort of the tried and true is the Child-Turco-Pugh class. This has been obviously around for a long time, but something that we sort of clinically assess at every visit. So patients that are Child Class A, if they have an absence of portal hypertension, they have normal platelets, no evidence of clinically significant portal hypertension, those patients generally are considered to be okay candidates for surgery. Of course, it depends on the type, but even for elective cases such as hernia repairs or urgent emergent surgeries, these patients tend to do well post-operatively. Patients that are Child Class B, for those patients, there may be some that can undergo an elective type of surgery, but that really depends on the particular patient. And then generally speaking, Child Class A is considered to be a relative contraindication to any sort of elective surgery. Of course, in urgent emergent cases, that may change, and at that point, all you can do is sort of do your best to manage those patients post-operatively. The issue with child classification is that it can be very subjective. I think this is something that's assessed at every clinic visit and is sort of intuitive. But in terms of actually providing the risk stratification, This is where this model is lacking. And so the MELD score is considered to be more objective, and it has gone through many iterations. Initially was the bilirubin, INR, and creatinine. Then in 2016, the sodium was added to that. And then most recently is the MELD 3.0, which was adopted by UNOS in our transplant population in the summer of 2023, and now includes those 4 variables in addition to albumin and gender as well. And so there was a retrospective study of 140 patients that were undergoing non-transplant surgical procedures that looked at basically whether a MELD score could be predictive of outcomes post-operatively. And these were patients who were undergoing major surgeries such as intra-abdominal, cardiovascular, urologic, musculoskeletal, and then other surgeries as well. And what they found was that patients that had a MELD of less than 16 had lower post-operative mortality. So again, similar to the child classification, this is something that's assessed routinely at clinic visits and can sort of guide whether a patient should or should not undergo an elective surgery. And then next is the Mayo post-operative mortality risk score. So this is a risk stratification tool that's a calculator, and I will be talking a little bit more about how to find that as well to use in our patients. So this was based on data that were published by Tay et al. From Mayo in 2007. There were almost 800 patients with cirrhosis that were undergoing major surgeries, which included digestive, orthopedic, cardiovascular surgeries, compared to those who were undergoing minor surgery. And what they found in their multivariable analysis was that only MELD score, and I put an asterisk by MELD because this was the original MELD, which included bilirubin, INR, and creatinine. Age, the ASA classification, were those variables that predicted 30-day, 90-day, and 1-year mortality. And here to the right is the Kaplan-Meier curve. So the dashed line at the very bottom are those patients that were undergoing major surgery. And then the darkest bar is those who are the controls. And then the in-between shade of gray are those that were undergoing minor surgery. And here you can see that there was a statistically significant difference in postoperative mortality amongst patients who were going major surgery as compared to those who were controls or undergoing minor surgery. And from there, they basically created this calculator, which can be found easily online, and uses those components that are known to predict mortality, at least in this patient population. And again, those factors are age, ASA classification, so those with compensated cirrhosis are considered to be ASA class 3, and those with decompensated cirrhosis are considered to be ASA class 4. And then, of course, the components of the original MELD score, and then the etiology. And so here I've just put a 62-year-old male with alcohol-related liver disease who is decompensated. I've just put those numbers, and here you'll just get essentially an assessment of their risk postoperatively. So next to talk about vocal pen. So this is another novel risk stratification tool that was published in 2021 and based on granular data from VA cohort. So this was a retrospective study of 4,700 surgical procedures in almost 3,800 patients with cirrhosis. And they categorized by surgery, actually. So abdominal wall, vascular, abdominal, cardiac, chest, or orthopedic. So these were major surgeries. And what they found was that predictors of mortality included age, preoperative albumin, platelet count, bilirubin, surgical category, emergency indication, fatty liver disease, ASA classification, and obesity. Here I've shown some the C statistics. So this is the area under receiver operator characteristic for patients using the vocal pen score. So in A and B, the curves on the left, you can see that A is for the derivation cohort for 30-day postoperative mortality, and B is the validation cohort. And you can see the numbers are small there, but for 30-day postoperative mortality, vocal pen did outperform the other risk stratifications such as Mayo risk score and MELD sodium. So vocal pen has actually since been externally validated into independent health systems as well, Beth Israel Deaconess and University of Pennsylvania. And the validation was done based on retrospective cohort of patients with cirrhosis who were undergoing surgery. And when applied, they found that the vocal pen also outperformed the Mayo risk score as well as MELD when it came to predicting 30-day and 90-day postoperative mortality. And here is a depiction of what vocal pen looks like. So this can be found easily online as well. And essentially asks for those variables that the authors did find predicted postoperative mortality, and is very easy to use. And then we'll also give data about 30-day, 90-day, 180-day mortality, as well as risk of 90-day decompensation. So there was an AGA article that was published by Northrop et al. In 2019 that was based on expert opinion. As I had mentioned, there's a lack of robust data to sort of drive this surgical risk stratification. And so therefore, this is based on expert opinion and tied to those retrospective studies that have been done before. So going through, kind of by surgery, what considerations? First and foremost, when a patient with cirrhosis is to undergo surgery, whether elective, urgent, or emergent, one should determine whether a patient is a liver transplant candidate. And that's not necessarily to have a patient listed for liver transplant prior to surgery, but just to know that if the patient were to decompensate after surgery, whether transplant candidacy is enough to have the patient listed postoperatively. And then going by surgery type, so for primary hepatic resection, so in patients with cirrhosis, the major indication for this would be an early stage HCC, and this can generally be considered in patients who are child class A without clinically significant portal hypertension, meaning platelets that are over 100,000, and then a portal pressure gradient of less than 10 millimeters mercury. For patients that may be considered for cholecystectomy, if it's true cholecystitis, they really should be referred to a liver transplant center. This diagnosis can also be difficult to make as well, because we know that in patients with decompensated cirrhosis, they may actually have gallbladder wall thickening that may indicate or look like cholecystitis, but is not actually truly cholecystitis. And we know that patients with cirrhosis who undergo cholecystectomy have a higher mortality rate than those without cirrhosis. These patients often also require a conversion from laparoscopic to open cholecystectomy, which can further complicate their postoperative course. And then lastly, with advancements in endoscopic techniques, endoscopic transpapillary gallbladder drainage is also an option, especially in patients who may be decompensated as well. Many of our patients do have abdominal wall hernias, whether it's a ventral hernia, umbilical hernia, and then inguinal hernias. And for these patients, control of ascites is key. There's often recurrence of the ascites in the postoperative period, and that can lead to certain complications such as poor wound healing and wound dehiscence. In patients with incarcerated hernias, this is obviously an emergent indication. Those patients do often have more complications than if this were to be an elective type of surgery. And because these patients that have the emergent hernia repairs done, because they do poorly postoperatively, some actually advocate for doing an elective hernia repair to prevent an emergent situation. And so this may be considered, especially in centers where there is surgical expertise in operating on patients with cirrhosis. And then in terms of cardiovascular surgery, especially when requiring bypass, there are many factors that go into an alteration of hemostasis and hemodynamics that can lead to hyperfibrinolysis and platelet activation. So you can get both bleeding and clotting. So this is generally avoided if possible, unless if in an emergent situation. And cardiac catheterization to address coronary artery disease is considered to be relatively safe in these patients. So they can certainly undergo that if need be. And then lastly, with bariatric surgery, this really is considered to be an elective surgery and shouldn't be performed in the presence of portal hypertension. Some people do actually advocate for doing bariatric surgery either at the time of liver transplantation or in the post-transplant period. Now with endoscopic bariatric procedures, this is also a possibility for our patients with cirrhosis, especially if they're compensated and in the absence of portal hypertension, they may be good candidates for endobariatric procedures. As I had mentioned before about the expert opinion that was published in AGA in CGH, these predictive models can be used by surgery type. Notably, the two that are not included are the Mayo risk score and vocal pen. But generally speaking, I think MELD and child classification is something that's assessed routinely at clinic visits. So, I would urge everyone to continue doing so, and then using the Mayo risk score and vocal pen with more detailed data. So some perioperative considerations, especially in the post-operative period in patients with cirrhosis, ascites is key. It should really be managed aggressively, pre-operatively, with diuretics, and then large volume paracentesis as needed. Generally speaking, surgeons or proceduralists really should limit intravenous fluids and blood products unless if they're absolutely necessary. And then preemptive tips is not recommended prior to any type of surgery, just simply for the indication of that surgery. In regards to hemostasis, there are no data to suggest that there is a certain threshold INR. We know that it's not predictive of bleeding, so therefore there are no routine guidelines on transfusing either cryoprecipitate or FFP in these patients. Generally speaking, platelets should be over 50,000, and that's just to ensure adequate clotting in the postoperative period. There are thrombopoietin receptor agonists as well that can be used, evatrombopag and then lucitrombopag. And this has been approved actually in patients with chronic liver disease to raise the platelet count. The one thing to really consider is by raising the platelet count, patients are at a higher risk of portal vein thrombosis and deep vein thrombosis. Aim to try to keep the fibrinogen over 100, especially in high-risk procedures. And then lastly, viscoelastic testing such as thromboelastography can be used to guide, perioperative transfusions. And then lastly, pain control in patients in the postoperative setting do require a limitation of opiates and benzodiazepines. There is a decreased hepatic metabolism with these medications and a potential risk of encephalopathy. So instead, if tramadol and acetaminophen less than 2,000 milligrams per day are adequate for pain control, that would be the preferred method. Avoiding non-steroidal anti-inflammatory drugs is also key so as not to precipitate renal failure or hepatorenal syndrome in this patient population. And then avoiding constipation is also important, especially in the setting of opiate use. Ensuring that patients have a bowel regimen is key so as to prevent any worsening of encephalopathy. So in summary, there's a rising incidence of cirrhosis worldwide and an aging population with comorbidities. So there are just more conditions out there where surgery may be considered or indicated. There are two novel risk stratification calculators, the Mayo risk score and the vocal pen score, that can be used, especially if there is a need to provide concrete data. And then perioperative considerations include adequate management of ascites, avoiding unnecessary IV fluids or blood transfusions, and avoiding opiates and benzodiazepines if possible. So with that, I thank you for your time.